Good morning, everybody. My name is Linda Sangalli, and I'm delightful to be among the speakers of this conference of the World Congress on Dentistry and Oral Health held in the Netherlands. Today, I want to share with you a recent line of my research with a presentation called A Proposal of a Stepwise Algorithm for the Management of Burning Mouth Syndrome. First, I want to start my presentation defining that I have no conflict of interest to declare. Now, here is a brief introduction of myself to understand how I ended up on this journey. So I achieved my dental degree at the University of Brescia in Italy in 2011. And I've also completed a master in orthodontics in the same university and consequently a PhD in technology for health. I've been working as a specialist orthodontist for almost 10 years in Italy, and then I moved to London, where I've been working as well as a specialist orthodontist for 2 years. Now, my journey ended up here at the University of Kentucky, where I'm currently involved and enrolled in a Master of Science in Orofacial Pain. And here you can see me with my two co-residents. Now, today I want to talk to you about burning mouth syndrome and the management and the most advanced research that I'm currently doing in the management of burning mouth syndrome. We will start the presentation with a definition of burning mouth syndrome, the way to make a correct diagnosis, and then we will move to what I think is the most interesting part of this presentation, which basically involves a stepwise algorithm on what to do when we have a case of burning mouth syndrome patient, especially for those who are refractory to the most traditionally considered treatment. Now, burning mouth syndrome. Different definition has been given to this condition. And these are the most accredited association and organization that over the year has provided a definition in order to accommodate all the conditions that were seen with a typical presentation. We can start with the ISP, with the International Association for the Study of Pain, that provided definition in 1994 of burning mouth syndrome considered as a chronic oral mucosal pain or discomfort where no identifiable cause is possible to identify. Now, the IHS, the International Association for the International Headache Society, in 2018, provide more detail to the definition by considering that there's no clinically evident oral systemic pathology, and it also provides with a temporal definition of characterization of this condition, which should last for more than 2 hours per day for more than 3 months. How about the ICOP, the International Classification of Orofacial Pain? Basically recognize all the same characterization by combining the two previous definition. And finally, the International Classification of Disease provide with a new modification of 2022, also characterize this definition as occurring 2 hours per day on 50% of the days over more than 3 months. Now, moving to the clinical features for which we can define burning mouth syndrome, the pain in BMS is moderate to severe on a scale from 0 to 10 on a numerical rating scale. It occurs normally bilaterally and symmetrically, and the main location, as listed here, are the tongue, especially the dorsum, followed by the palate, the buccal, the labial mucosal, the lip, and the gingival area. Stress, acidic food are the most identified by our patient as aggravating factors. And patients also report that by the end of the day, the pain normally worsens with a peak in the evening. And in a review by Scalea in 2003, there was identified that 73% of the BMS patients also may experience tingling, tender scalding, and the numbness of the oral mucosa. As for the epidemiology of this condition, we can identify that the female gender is the most involved, with the incidence estimate for 5 out of 100,000 people, and it normally occurs in the adult population between 1 and 5%. Now, different terminology has been used to identify this burning sensation in the mouth. And over the past 3 decades, the experts in the field have questioned whether the term syndrome or disorder should be used. The current term, BMS, implies that the condition being classified as a syndrome. However, a syndrome, as for the definition, is defined as an aggregate of symptoms and signs associated with any morbid process, together constituting the picture of the disease. Conversely, a broad range of symptoms has been reported with BMS, and among the broad variety of symptoms, the only consistent one required for the diagnosis is a sensation of oral burning or dysesthesia. And for this reason, experts have suggested that we might want to re-examine the nomenclature and the disease definition of BMS. Now, other terminology that you can find in the literature account for stomatopyrosis or oral dysesthesia. And when the pain is localized on the tongue, it can also be named as glossodynia, sore tongue, burning tongue, or glossopyrosis. The diagnosis of BMS is generally not difficult to achieve. As we mentioned earlier, the only characteristic, pathognomonic characteristic, is the symptom of burning pain. So therefore, the diagnosis of burning mouth syndrome is basically a diagnosis of exclusion. And if any of the following underlying medical or dental factors were found, this was previously identified and referred as a secondary burning mouth syndrome. So especially in the case of the diagnosis of exclusion, having in mind a precise and rational steps help to achieve a correct diagnosis in addressing any confounding factors, as well as in identifying a rational approach for management, especially in those with a refractory condition. Therefore, here I'm presenting a stepwise algorithm that can help defining which step should be performed in a logical sequence. And we will define and see them in details. So first of all the staff working in a university or in a private practice should be trained to acquire the information displayed in this step, the first and the second step, so that these data are previously collected prior to the appointment. So let's start with this proposed algorithm. The step 1 refers to the medication. So a thorough collection of daily prescription and over-the-counter medication should be performed, as there is evidence in the literature that some of them can play a role in the development of burning mouth syndrome in the mouth. The most common ones regarding the medication are the angiotensin-converting enzyme inhibitor, which are also commonly encountered in the list of daily medication of our patient population. And here you can see highlighted the most involved one. And also other classes of medication that can initiate or sustain a burning sensation are, for example, the angiotensin II receptor blockers, antiretrovirals, the selective serotonin reuptake inhibitor, selective serotonin and norepinephrine reuptake inhibitors, anticonvulsants, and hormone replacement therapy. Now, once we have identified in the list of our patient medication which one, if any, can actually sustain a burning mouth syndrome, we might want to see if there's a possibility to have the patient discontinue one of those potential medications. However, let's say that we exclude that any of the medication might be the explanation for the etiology of our burning mouth syndrome. In that case, we move to the second step. So step 2 of this algorithm consists of a diagnostic investigation. In particular, first of all, one fundamental diagnostic investigation is the request of blood work. Why do we want to request blood work? Because there are some systemic conditions that can mimic and present themselves as a burning sensation. In particular, we want to request a comprehensive metabolic panel, checking for electrolyte, glucose, renal and liver function. Precise blood tests should be also run to exclude any autoimmune disease, like Sjogren's syndrome, anti-nuclear antibodies, a thyroid panel, to explain and to exclude the consequent and corresponding systemic disease. So we saw a list of possible systemic conditions that can actually most likely be implicated in the etiology of secondary burning mouth syndrome. However, what we noticed in our patient at the Orofacial Pain Clinic at the University of Kentucky was a high prevalence of patients with GERD among those referred for a complaint of burning mouth syndrome. And this high prevalence is also supported by some degree of evidence in the literature, although controversial. Therefore, due to the inconsistent literature regarding the relationship between BMS and GERD, we conducted a retrospective study in our clinic looking at the prevalence of GERD in patients seen for a complaint of burning mouth syndrome, and also looking at the presence and association of xerostomia and hyposalivation in those patients with GERD and burning mouth syndrome. So right now I will present to you a current study, which was a retrospective study of those medical charts collected between 2014 and 2020 of those patients seen at the Orofacial Pain Center at the University of Kentucky. To be included in this retrospective review, the medical chart needed to have a diagnosis of glossodinia and to have an oral burning pain rated greater than 0 on a 0-10 numerical rating scale. And the chart were excluded if the patients complain of oral burning because of a known condition, like the one that we saw earlier. So anemia, oral lesion, diabetes mellitus, Sjogren's syndrome, autoimmune disease, vitamin deficiency, or medication. And the chart were also excluded if the health record had any missing data. The procedure that was carried out in our study consisted, first of all, of a clinical exam that was conducted by a diplomate of American Board of Oral Medicine. Now, the chief complaint of a burning sensation was investigated by ascertaining the pain location, the quality, the frequency, duration, the presence of taste disturbance, triggering, aggravating, or relieving factors. And the pain intensity was collected on a 0-10 numerical rating scale. And then we moved to the medical history. So a thorough medical history was collected, which investigated any systemic medical condition with specific attention on GERD, which was defined by the patient self-report, and then from a comprehensive review of systems, and also by inquiring whether the patient received a diagnosis of GERD from the treating physician. The medical history also included the sleep assessment, the presence of parafunctional habits, alcohol consumption, smoking status, and daily physical activity. Another variable that was collected for the study was the number and types of prescribed medication, with a particular focus on those that are normally associated with xerostomia. And xerostomia was also assessed as defined as a subjective complaint of dry mouth. And this was either self-reported by the patient or assessed with a short-form xerostomia inventory questionnaire. What is this xerostomia inventory? So in our clinic, beside inquiring if a patient has a dry mouth, just by asking them, we also assess the xerostomia using a xerostomia inventory, which assesses the severity of xerostomia on a Likert scale, in the long form here listed, or in the short form that we most commonly use in our clinic. A cutoff of 10 identified a clinical xerostomia, although we use a 10 as a cutoff, although it was not particularly clear in the original paper. In order to assess the hyposalivation, unsimulated whole salivary flow was measured by instructing the patient to allow the saliva to collect in the mouth and split into a cup for every 20 seconds for 5 minutes, while sitting upright in a undisturbed and comfortable position. The samples were collected between 1 p.m. and 4 p.m. with participants not eating nor drinking for 1 hour before the procedure. Hyposalivation was defined for our study as was having a salivary flow measurement below 0.2 milliliter per minute. And here is the statistical analysis of what we were looking for and how we assess our variable. And as the result of this retrospective analysis, we defined that 134 patients were diagnosed with BMS, with a mean age of 63 years. And a prevalence of female gender that were consistent with 80% of our patient population. The mean pain intensity, as you can see here, was 6 out of 10, and 38% of our population reported a taste disturbance. And on average, patients had 5 systemic medical conditions, with hypertension being the most common in 44% of them. A complaint of dry mouth was commonly found in 64 patients, so in 79% of them, who responded to the intake question about xerostomia. And 59 of those that were diagnosed with BMS, which is basically 44%, also reported to suffer from GERD. And a prevalence of 44% of GERD in our patient population is way higher compared to what encountered in the general population in the United States, which goes from 18 up to 27% of the population. So the first aim of the study was to confirm that the prevalence of GERD in a population of burning mouth syndrome is indeed significantly higher than normal. And instead, no difference was found in xerostomia in dry mouth between patients with GERD and with no GERD symptomatology. Now, in terms of number and types of medication, a mean number of 5.5 medications were taken, and more than 3 of them were considered xerostomia medication, according to recent reviews. And the most common xerostomia medication were SSRI, omeprazole, and non-steroid inflammatory drugs, so NSAID. And the 2 groups did not differ in medication use, except for the use of omeprazole, which was clearly most common in the patient with GERD symptomatology. And here we can actually see that the rest of the other medication was not different between the 2 classes. Now, salivary flow was measured in 104 of the total patients, so in 77% of them. And 65% of the total number of patients had hyposalivation. As for the hyposalivation, this was detected in 61% of patients with GERD. However, no significant difference was found in the unsimulated whole salivary flow between patients who reported GERD and between patients who did not report GERD. And the lack of this association is in accordance with 4 reports in the literature, but is also in contrast with 5 other reports in the literature. And the possible explanation of this difference might account for the difference in GERD diagnosis, in the method of salivary flow collection, or in the controlling or not of the medication intake. Now, moving back to our algorithm, beside ordering blood work to exclude systemic condition, which we have seen that is particularly present in certain subpopulation, we should also routinely measure the salivary flow, do the serology, and also collect fungal culture. So let's see each of them. The serology. Why do we want to do serology? We can hypothesize that the patient might need a serology assessment if we think that there might be a virus infection, in particular of the herpes virus, HSV 1, 2, or the varicella zoster virus. If we have the suspect that the patient might also have a fungal infection, we may want to take a fungal culture. And in that case, if it turns out to be positive, we might need to address it with nystatin, with clotrimazole, and all the other fungal medication that we find appropriate. Now, what if the patient has also hyposalivation? The only way to assess the hyposalivation is obviously to measure the salivary flow. The salivary flow is tested by collecting the resting flow or the unsimulated whole saliva and the salivary flow as shown in this table. In addition, parotid salivary flow can also be collected. The salivary flow measurement should be performed as a first thing in the morning after overnight fasting, with no food or drink nor smoking for at least 1 hour before the test. And most of the literature recommends to run this test for 5 minutes, although also longer time duration is also suggested across the study. Now, the importance of collecting salivary flow rate is that, according to a systematic review, the salivary gland dysfunction is lower than objective salivary gland dysfunction. Therefore, many patients might not even be aware of having any hyposalivation, with a percentage that goes between 16 up to 54 instead of those that indeed have a hyposalivation. And across the study, something else that we can acknowledge is that females and elderly have significantly lower salivary flow rates than males or younger individuals, respectively. Overall, the simulated salivary flow should be 3-4 times the unstimulated salivary flow, as we can see here in this values range in this table. And generally, the simulated whole salivary flow is less susceptible to variation. And across the study, we can see here different procedures to collect it. And in our clinic, we use the sugar-free lemon candy. Lastly, the simulated parotid salivary flow can be collected with the use of a Lashley suction cup placed over the orifice of the Stenson duct on the buccal mucosa. Now, why we should address the hyposalivation? Well, because it seems from the literature that there might be an association between BMS and hyposalivation. And here we can see a brief summary of what we see in the literature on the association between BMS and hyposalivation. And in this study, the prevalence of hyposalivation ranges between 33 and 100%, with a mean of 56%, and an outlier identified the presence of 9% of prevalence. Moreover, those studies that have measured the objective amount of saliva in patients with BMS also show that at least half of the studies demonstrated hyposalivation in this patient, and the remaining have a low flow. However, although it's clear from the literature that a higher percentage of patients who complain of BMS also generally have hyposalivation, we normally do not focus our treatment on addressing the hyposalivation. And this is a concept that I will connect it to in my presentation after. Now, moving forward with step 3, we should do a precise and thorough clinical examination. A clinical examination is fundamental to identify intraoral mucosal and also oral dryness of a mucosa. A thorough intraoral examination should be conducted specifically because some intraoral lesion may mimic the BMS. And this lesion may include the fungal infection, stomatitis, pemphigoid, pemphigus, neoplastic lesion in the oral cavity, traumatic lesion secondary to denture design, tooth restoration, herpes simplex or herpes zoster, or trauma to allergic stomatitis. So we should also and always inquire if the patient changed the toothpaste, if there was a new dental filling performed, in order to identify possible initiating agents. Now, the second thing that we want to identify in the clinical examination is the presence of xerostomia or dry mouth. Now, let's precisely define this term, as in the dental world, there's a little bit of confusion on what is dry mouth, what is xerostomia, and when should we call it as a hyposalivation. Dry mouth and xerostomia are basically the same concept, and they do express the subjective complaint of dry mouth. Conversely, hyposalivation is a term that requires the collection of the salivary measurement. Now, we know that xerostomia is considered among the symptoms presented by the patient with burning mouth syndrome. And so it is important to address and to assess for the dry mouth. So how do we do it? Besides assessing with the xerostomia inventory by directly questioning to our patient, as we saw before, we can also assess it clinically, as suggested by Chalencom in 2012. So here we can see a list of clinical findings that were found to be very well correlated with oral dryness, such as the observation of thick mucosa, our mirror that sticks to the buccal mucosa and to the tongue, or among other here listed. Now, the correlation between BMS and xerostomia is also supported by the literature that identifies a prevalence of BMS that varies between 16 up to 100. So actually, as you can see, the literature identify a very broad range of the prevalence. However, the average prevalence can account for 63%. And if we remember well the prevalence that we saw before for hyposalivation in BMS patient, that account for 56. So the percentage of individuals with BMS that also complain of xerostomia is higher than what we objectively found. However, as we just saw, the study in the literature suggests a presence of a relationship between BMS and hyposalivation and xerostomia. But they're kind of controversial because they also identify a broad range of prevalence. However, this possible association is also confirmed by our clinical experience with our patient. However, some of the findings are inconsistent across the literature. Therefore, due to what we just mentioned, we decided to conduct a retrospective analysis of our patient population referred for burning mouth syndrome, looking at the correlation between BMS pain intensity and low salivary flow, by investigating if the treatment of dry mouth can positively influence the pain intensity in burning mouth syndrome patient. And specifically, we aim at determining the relationship between salivary flow and BMS pain intensity, and determine if the treatment of hyposalivation reduce the pain intensity of BMS. And we also look at the relationship between medication and BMS by investigating the number and the type of xerostomy medications and pain intensity, and the relationship between xerostomy medication and hyposalivation. Now, same data collection that we saw before, so patients seen between 2014 and 2020 at our oral-facial pain clinic at the University of Kentucky. Inclusion criteria to be considered for the retrospective analysis were patient diagnosed with BMS with no other apparent oral lesion or condition. Oral burning present for at least 3 months, more than 2 hours per day, according to the definition provided by the most recent organization. Then presence of a complete electronic health record that would contain the unsimulated salivary flow, xerostom inventory for the first aim, and numerical rating pain intensity and unsimulated whole salivary flow for the aim 2. And then finally, also patient that completed the treatment with a dry mouth protocol or any other treatment with at least 2 visits, with a second visit being at least 3 months after the baseline for the aim 3. And finally, for the aim 4, we consider those with a list of current medication. We indeed, we instead excluded this chart. So those with the other diagnosis of a oral disease or neuropathy, which would explain the burning in the mouth. Those with no record of unstimulated salivary flow, xerostom inventory, pain intensity, or those who were not provided with any treatment plan, and those with a lack of the current medication list. These are the variables that were collected. First of all, salivary flow, which was collected accounting for unstimulated and stimulated salivary flow. The unstimulated salivary flow was collected, as explained earlier, and for this study, we consider a cutoff of 0.2 milliliter per minute. Whereas those whose salivary flow ranged between 0.2 and 0.4 were considered having low normal salivary flow. To collect the stimulated whole salivary flow, a lemon sugar lozenge was used as a stimulant. And saliva were collected for 3 up to 5 minutes and measured by a diplomate of the American Board of Oral Medicine. And we consider as impaired salivary gland dysfunction when the stimulated salivary flow was below 0.5 milliliter per minute. And as seen before, the pain intensity was assessed on a 0.10 numerical rating scale. The daily medication use was investigated in a number and type. And finally, the type of treatment was assessed and collected for the variables. And in case of hyposalivation or low salivary normal flow, this a dry mouth protocol, as listed here, was provided. And as we can see here, all these recommendations are made to maintain a good oral hygiene, to enhance the moisture of the mouth and the oral mucosa, and to increase the hydration by increasing the water intake and by using artificial stimulants. Now, we collected our variables and we performed the statistical analysis in order to evaluate the groups by defining in those patients that were taking 0 medication, taking 1 medication, or taking 2 or more medication, with particular emphasis with xerostom medication. So, going to the results of our study. Out of the 124 participants that were considered in this analysis, only 15% had a normal salivary flow. And not much surprising, but according to our hypothesis, 65 of them had hyposalivation, and 20% had an additional low salivary flow. The main pain intensity at baseline was 6 plus or minus 2 in a numerical rating scale from 0 to 10. And in association, actually, between unstimulated salivary flow and pain intensity was not found by Pearson correlation. And the mean pain intensity at the follow-up visit was 3 on a rating scale between 0 and 10. So this means that there was a statistical reduction pain intensity between the first visit and the visit 2. And this actually, contrary to our expectation, was achieved regardless of the treatment provided. And the most common treatment that we performed was a dry mouth protocol. This was provided to 21 patients. And of those, 9 patients reported pain reduction of at least 50%. And antifungal was provided most commonly to those with hyposalivation who yielded also positive to the fungal culture. And what does the literature say regarding this change in pain intensity and when we treat by hyposalivation? Well, few studies in the literature has evaluated the effect of treating the dry mouth and the hyposalivation as a mean to decrease the pain intensity, with, we can say, contradictory results. This lack of treatment effect derived from the improvement in salivary flow is in accordance with a study done by Co in 2012 that found that intraoral burning improved with the trial of clonazepam regardless of the salivary flow rate. And another study tested the efficacy of the parafunctional activity and the topical lubricant to be applied on the tongue 3-4 times daily for 10 minutes on burning mouth syndrome pain intensity in 25 patients. Although the study concluded that the salivary flow rate did not influence the treatment outcome. Conversely, another study found that approximately 37% of the patients with a chief complaint of oral burning and dry mouth partially or totally improved over time when salivary substitutes were introduced. And similarly, another study confirmed a significant reduction in pain intensity, in taste disturbance, and number of burning sites when 26 burning mouth syndrome patients were treated with salivary mechanical stimulation. Now, moving forward to our result, 72% of our burning mouth syndrome patients reporting taking 2 or more xerostomy medication. And only 13% of the total participants did not report any daily xerostomy medication. However, there was no association between pain intensity and the number of xerostomy medication between groups at the first visit. And in addition, also in the second visit, there was no association between pain and xerostomy medication. And however, a significant negative correlation was found between number of medication and unstimulated salivary flow. And similarly, a significant negative correlation was found between the number of xerostomach medication and unstimulated salivary flow. And this negative association between number of medication and hyposalivation is concordant with many other prior reports in the literature. And moving to our last result, this figure displays the overall mean unstimulated salivary flow in patients with a daily use of xerostomy medication. And we can see that those with a daily intake of trazodone or cyclobenzaprine alone or in combination with another drug had the lowest unstimulated salivary flow rate. And those using omeprazole did not present with hyposalivation, as we can see that it's higher than the cutoff of 0.2. And in particular, in our study, the lowest unstimulated salivary flow were observed with patients with glossodinia who were taking a daily combination of xerostomy medication. And this is also concordant with other reports in the literature that confirm that strong xerostomy medication are associated with hyposalivation. However, so this finding also highlight the difficulty in the management of glossodynia. That is, how do clinicians who treat patients with glossodynia should eliminate hyposalivation when the xerostomy medication are needed for the management of the condition? So it is difficult to answer this question because what do you do if this patient needs the medication they are on? So in our clinical experience, we try to have a responsible conversation with our patient. We try to see what is possible to eliminate from their daily medication regimen and what we can maybe substitute with adopting healthier lifestyles or by introducing behavioral intervention. And so this conducted to the next step. Step 4. Among all the pharmacological and non-pharmacological therapeutic approach to BMS, as proposed by systematic reviews and meta-analysis, clonazepam is proposed as the most widely accepted treatment for BMS. Clonazepam is an anticonvulsant which acts on a GABA inhibitory neurotransmitter. It has been proposed for topical or systemic use. And the reason why clonazepam might help alleviate pain when topically applied is because the fungiform papillae on the anterior 2/3 of the tongue have taste buds which GABA-A inhibitor receptor might work. However, systemic medication come with a side effect that we can see here listed. And also, despite the presence of so many possible pharmacological and non-pharmacological approaches, still the management of BMS is oftentimes unsatisfactory, with the number needed to treat of 4 to be able to see significant outcome in our pain reduction in our patient. Therefore, especially for those cases that are not well controlled with a traditional approach, new avenues can be considered, such as indeed what we propose here of low-dose naltrexone. Naltrexone is a competitive opioid receptor antagonist with a high binding affinity to the mu opioid receptor and lower binding affinity to delta and kappa opioid receptor. So the underlying mechanism of low-dose naltrexone is not well understood. The centrally mediated analgesia is supposed to be the result of the intermittent blockage of the opioid receptor and of the upregulation of endogenous opioid. Although these last information and data were actually put in doubt in animal studies. Now, the inhibition of peripheral inflammatory response mediated by the toll-like receptor 4 might also play a role. As we can see here, and we also the other consequences of a decrease in the pro-inflammatory cytokine or inhibition of the excitatory receptors. Now, I'm going now to present a case report that I'm very proud of, and I'm very satisfied for the outcome that we received. It was also recently published in the Type-O journal. So this is a story of a 62-year-old female that was presented in our orofacial pain clinic at the University of Kentucky with a chief complaint of burning mouth. So the patient reported that her pain started after a dental extraction performed 3 years prior to our visit. And it was at first located in the region of extraction. However, 1 year later, the pain migrated to the dorsum of the tongue. Next, a daily systemic clonazepam was introduced with very little reduction in pain, and therefore the patient was referred to our orofacial pain clinic 1 year later. Now, the quality of the pain was described by the patient as tingling or burning, with a reported intensity that fluctuated between 2 in the morning up to 8 out of 10 in the evening. And talking, stress, dry mouth, and eating sugary food were listed among the aggravating factors. As for the relieving factor, she pointed at chewing gums, ice, eating, drinking, and plain medication such as clonazepam indeed, or lozenges in the relieving factors. Now the patient was initially prescribed clonazepam 1 milligram per day by her general dentist, which has been using for 1 year with limited pain reduction, which went from 10 out of 10 up to 8 out of 10. And then a trial of lidocaine mouthwash did not have any effect. The patient medical history was significant for many other chronic pain conditions, including fibromyalgia, GERD, IBS, headache, interstitial cystitis. And as for hypercholesterolemia, depression, anxiety, they were all well controlled with medication. We also asked her to rate the pain intensity coming from the painful medical condition, which were rated as here presented. And the highest impairment, according to the patient, derived from her interstitial cystitis, with a pain intensity rated by 7 up to 8 out of 10. And the current medication regimen only included omeprazole taken daily and fluoxetine, and of course clonazepam for her current burning mouth syndrome complaint. A cranial nerve examination failed to reveal any abnormalities. Palpation of the musculoskeletal or facial muscle and temporomandibular joint did not evoke any pain or tenderness. And the intraoral exam, including the examination of the lip, labial mucosa, buccal mucosa, anything failed to reveal any abnormalities. How about laboratory findings? Moving forward to our stepwise algorithm, right? So the patient reported a diagnosis of primary burning mouth syndrome, which was given by her neurologist. After blood tests were done, which excluded any abnormalities in the level that we can see here in the first box. At our end, we did the xerostomia severity assessment, which yielded to a number of 10 out of 25, which define basically clinically significant xerostomia. In intraoral fungal swab was negative for candidiasis, and her unstimulated salivary flow and her stimulated salivary flow detected a 0.03 millimeter per minute and 2.7 millimeter per minute. So, in light of the history, neurological, clinical, laboratory investigation, and in light of her hyposalivation, we gave a diagnosis of burning mouth syndrome, and also hyposalivation was added as a potential contributing factor. So we warned the patient of the link between the two and of the necessity to treat both conditions. Her hyposalivation was assessed and addressed by providing a dry mouth protocol, as previously seen. And lastly, an increase in the clonazepam dose or its topical use was discussed. But the patient dismissed this option, and therefore we put the patient on a low-dose naltrexone. Why? This was mainly driven because of retrofractory intraoral burning complaint, the ongoing clonazepam administration, the associated widespread chronic comorbidities of fibromyalgia, IBS, depression, interstitial cystitis. Therefore, the patient accepted, and after a clearance from the primary care physician, we introduced a low-dose naltrexone at bedtime with initially a dose of 1.5, slowly titrated to 4.5. We decreased a little bit to 3.3 milligram because of tiredness as a side effect. And here the evolution of her pain intensity, not just of the burning mouth syndrome, but also of all the other chronic pain conditions. So we can see that after 1 month of daily 4.5 milligram of the lower dose naltrexone, there was a dramatically decrease in the pain intensity of the burning mouth syndrome. But actually, at 2 months, everything dropped by 50%. So we can see that actually all the other chronic pain conditions also decrease. Then there was an adjustment in the dosage at 3 months because the pain reduction decreased. So after putting a patient on a steady and daily dose of 4.5 milligram of low dose naltrexone, we had basically more than 50% of reduction, as you can see here in the graph, from the 4 months up to the 6 months follow-up. And what can we see in the literature regarding the low dose naltrexone? These are the clinical studies that has been already conducted in the literature, and all of them are supportive and very stimulating regarding the fact that the low dose naltrexone can be a potential treatment management for painful condition, especially for those patients that indeed do have not only a localized pain condition, but a more widespread chronic pain mechanism. As for the literature of low-dose naltrexone for burning nose syndrome, only one case report exists to date in the literature. This was published in 2021 by Newman and Chadwick. And our two case report are similar for the presence of overlapping chronic pain condition. In fact, in the case of Newman's, the patient also suffered from anxiety, depression, IBS, fibromyalgia, beside the burning nose syndrome. The medication regimen of our two patients were actually very similar, although in the case of the Newman et al., clonazepam 2 milligram daily was used. Both patients began noticing a 50% of reduction in their pain after a few weeks. And the maximum benefit was achieved with a 4.5 milligram, with a pain reduction in actually all the systemic painful conditions. And the only thing that was different was that between our two studies, that in the low-dose naltrexone in the Newman study, the patient was actually just experiencing a pain of 2 out of 10, whereas in our case was 8 out of 10 pain. So we finally concluded this presentation, and I hope that you had fun and you find it interesting as well as I do, because this is a very recent line of research of mine, but I'm very fond of this, especially because of the discoveries that every time we are achieving with our curiosity putting into studies that we can conduct. So here I'm going to present again and repropose the algorithm, which basically is very important for those patients which might have been left undertreated or mistreated if we do not have a rational, stepwise sequence of our management treatment plan. And therefore, I'm leaning toward the end of this presentation, where I want to thank and acknowledge the rest of my team that work with me at the University of Kentucky. So in particular, Dr. Miller, Dr. Eldomiati, and Dr. Rojas from my university. And I thank them for the ideas of conducting these studies, of the hard work that generally identify our team here. And so I'm very grateful to have had this opportunity to present you with my latest research. And here my email, where I absolutely will be very happy to respond to any question that you might have, or any feedback that you want to give me, to provide to me for my presentation. Thank you so much. Bye-bye.